Good morning, everyone. Happy Thursday. I'm Dr. Scott Martin. This is the Institute of Regenerative Education. Whether you're joining us on Facebook or whether you're on our website, we are very delighted to have you. Now, this is going to be a very complicated lecture, and I just want everyone to kind of settle in and ease in. I've spent at least a week and a half, if not 2 weeks, preparing this. There are going to be a laundry list of receipts below this lecture so you can read around this. There's a reason I'm giving this lecture. We as physicians consider ourselves the tip of the spear if we're in regenerative medicine. Well, to stay that way, to stay the tip of the spear, it's completely essential that, number one, we peruse literature pretty aggressively. And number two, we look for consistencies in systemic disease and practical ways to address these problems. Now, classically speaking, if I said, you know what, neurodegenerative processes, diabetes, cardiovascular disease, and say systemic osteoarthritis, they seem rather disparate. Would it surprise you that they're not that disparate? And as a matter of fact, there is a central underlying principle that drives pathology in all four paradigms. Now, please understand, this is all very experimental use. I'm going to put up here in the corner, like I usually do on these videos, because this is going to raise some eyebrows. The FDA is your friend, right? We cannot use any of this to diagnose, treat, cure, or prevent disease. This is 100% experimental use, a little theoretical, right? But there is tremendous opportunity here when it comes to modulating disease, because there is a central paradigm that unifies cardiac, systemic pain conditions, neurodegenerative processes, as well as diabetes. And we're going to go through it. I am not a cardiologist, so please give me a bit of grace. I am a pain doctor, right? But irrespective, I'm never going to be the smartest pain doctor in the country, not even close. I'm definitely not a neurologist or a neurosurgeon, and without question, I'm not my wife. I'm not an expert in diabetes. And so we're going to be talking in general terms. If I get something that isn't quite perfect, I beg your forgiveness. But let's work through this. Now, the title of this lecture is The Nose Knows. And the reason I put this lecture together is that I've been getting more and more questions about nebulized application of biologics. It's becoming hot. People are excited about it. I nebulize myself, right? I have seronegative spondyloarthropathy. I also have, not diabetes, but I have Graves' disease. And my father's father died in his early 40s from Parkinson's. I'm a twin. My twin brother has no issues. So if someone's going to get Parkinson's, and I already have autoimmune arthritis and autoimmune thyroid, who's the most likely person to get Parkinson's? It's most likely me. So this impacts me without question. My father also had a 5-vessel cabbage at the age of 74. 5-vessel occlusion. And the only reason he was alive is that my father had a partial Christmas factor. meaning his blood was incredibly thin. I remember riding bikes with him when we were young, and we had just gotten brand new 10 speeds, and my dad was wearing sandals of all things. He was post-call, he was completely exhausted, but my dad was a frickin' boss. And he came home after being on call doing God knows how many cases, and he had stuffed 3 brand new 10-speed bikes in the back of a Suburban. One for my twin brother, one for me, and one for himself. His was black, my brother's was blue, mine was red, and I hate red. Well, the old 10-speed bikes had these really sharp pedals on them, so they would hold onto your feet. My dad was just tired, he didn't grab tennis shoes, he went and put sandals on, and his foot slipped off the pedal when we were racing around the neighborhood. I had not seen that much blood come out of anything in quite some time. And I grew up in Missouri, and we were culling cows and shooting pigs, and I had to skin and, clean out my own deer when we went hunting. But I mean, seeing your dad just kind of bleed all over Hell's Half Acre, that was impressive. But his partial Christmas factor kept him alive, because at 74 he had a heart attack and he had 100% occlusion of all 5 cardiac vessels. But he had a basket of peripheral collateralization around the heart that kept his heart alive. It's the only reason he survived. I don't have partial Christmas factor, so cardiac disease runs in my family as well. So if you think that all of this research was just for all of your benefit, it was for my benefit as well. So let's get into this. Why am I calling this the nose? Well, I was asked to look at a device. And I'm not going to detail the name of the device, but it's an intranasal device that drives nearly 95% of a biologic intranasally, targeting the sphenopalatine ganglion in the olfactory mucosa. And it does so over about 15-20 minutes. Now, all of us have used nebulizer masks, and we've all been looking for something that's more efficient, where you don't lose biologic out the sides of the mask, right? Or you don't lose it out of the face mask. Well, this drives 100% of the biologic right to the sphenopalatine ganglion, well, 95% of the biologic, to the sphenopalatine ganglion in the olfactory mucosa, to directly impact cerebral circulation. That's hot. That's really, really interesting. Now, the device isn't cheap, but you can use this device on an infinite number of patients. And the little cartridge that you use, you replace on an annual basis. Cartridges are like $300. Hell, skin pen microneedle cartridges that you replace every patient are $86. So if I could do 500 intranasal applications and spend $300 to replace that in a year, that's like free money to me, And again, we're not going to get into what the device is specifically, because I don't want to distract from the education component of this. The folks over at Platinum are looking at the best intranasal device to use. And I was already on this, and they said, look into this and see if there's a central unifying theme wherein this could be used to dramatically impact societal health. Now, cardiac disease is still the #1 killer of adults in the United States, right? Pain, we still have around 100,000 overdose deaths from narcotics, and all of those patients have addictions, the majority of which those addictions started because of pain. Neurodegenerative issues are becoming far more prominent in the United States, right? Some of it is because of diabetes. 35% of the US population is diabetic. By 2030, they expect that about 40% of the US population will be diabetic. Dementia in the United States doesn't exist anywhere else because they don't call it dementia. anywhere but the US. Everywhere else, dementia is considered type 3 diabetes. So yeah, uncontrolled blood sugar can portend dramatic increase in risk for neurodegenerative paradigms. So what's the unifying paradigm between all of this? And how could we theoretically, experimentally use an intranasal device to deliver a biologic that would affect all of these? We're talking about the experimental use of an exosome product, and in particular, an umbilical cord-derived exosome. Specifically, an umbilical cord differentiated mesenchymal stem cell derived exosome. If you're using platinum products, probably something like Nano Air, maybe even Nano Air Plus. What do we know about all of these paradigms? Well, we know if we reduce inflammation, we can actually dramatically improve all four of these. Reducing inflammation reduces NF-κ-beta induced inflammation. It reduces inflammasome activity. It reduces central sensitization to pain. It reduces central sympathetic tone. And it reduces central activation of the hypothalamus. Now let's look at this in a bit more detail. Let's take cardiac disease first. We know in general terms the paradigm that happens with cardiac disease. Central elevation of inflammation, central elevation of TNF-alpha, IL-6, IL-1 beta, leukotrienes ends up causing inflammation and increased vascular permeability in smooth muscle. The very muscles that are around our cardiac vessels. In conditions like smoking, obesity, even diabetes, congenital issues like homocystinemia and even high cholesterol. Elevations in cholesterol deposits slide under the endothelial layer in smooth muscle. Once those cholesterol deposits slide under that endothelial layer, they start to form a foam cell. That foam cell then forms a streak, and the body responds to that foreign body, that immersion of cholesterol deposits in the smooth muscle of a vessel, no different than, say, your body would respond to radius or sculpture injected into your face. It's a foreign body. So what does the body do? An M1-driven macrophage process ends up causing upregulation of fibrin deposition, and that fibrin deposition creates a fibrin cap. Now, the initial paradigm with that fibrin cap is that is an unstable plaque. That unstable plaque is also at the highest risk of rupture. What would cause that plaque to rupture? Well, there are other signals that happen with increase in systemic inflammation, notwithstanding increased osteoblast activity in the smooth muscle of blood vessels. That osteoblast activity, more type 1 collagen deposition in blood vessels, hardens the vessels, makes them less pliable, and increases blood pressure. With increased blood pressure, with persistent inflammation and an unstable plaque, you get plaque rupture. Shedding of cholesterol deposits, plugging of a blood vessel, and symptomatically you suffer a heart attack. So theoretically, on an experimental basis, if I could use an exosome by intranasal route of administration, I could systemically downregulate NFK beta, systemically downregulate osteoblastic activity in blood vessels. I could systemically downregulate inflammasome paradigms, right? Upregulate nitric oxide that would cause vasodilation of those blood vessels. Ideally, I could slow the process of that fibrin cap formation, prevent the rupture of unstable fibrin cap plaques, right? And potentially forestall cardiac events. That is hot. Number one driver of death in the United States is cardiac disease. And on a theoretical basis, intranasal application of exosomes with central reduction in inflammation, centrally downregulating IL-6, IL-1 beta, TNF alpha, NFK beta, inflammasome paradigms, upregulating IL-10, upregulating ARG1, upregulating eNOS in nitric oxide disbursement, down-regulating calcium deposits in blood vessels, down-regulating the inflammation that ends up making the smooth muscle permeable such that cholesterol deposits can slip in, may in fact impact cardiac health long-term. How would we know? Observational studies. Circles back to the IRB that we are about to get approval for through the Institute of Regenerative Education. It's fabulous, right? Many of you are primary care doctors. Some of you are naturopaths. Some of you are integrated, medicine providers. I don't care if you're neurosurgery, you're still seeing patients that have cardiac disease. And even if you're neurosurgery, before you operate on somebody, you have to get what? Cardiac clearance. So whether you're podiatric medicine, integrated chiro, neurosurgery, nurse practitioner in an aesthetics clinic, right? Cardiac disease is affecting every single one of your patients. Okay, that's cool. What about pain? Well, let's look at pain. What happens when somebody's suffering from pain? When someone's suffering from pain, we get central sensitization. We get upregulation of systemic inflammatory mediators, which turns on substance P, which turns on excitatory amino acids, glutamate, aspartate, calcitonin G-related peptides. Central inflammation increases sympathetic tone. That increase in sympathetic tone also drives pain responses. It lowers the threshold for pain receptors to fire. But if we can modulate inflammation systemically, what do? Stabilize the balance between sympathetic and parasympathetic tone. Normalize the threshold for pain receptors to fire. Reduce the sensitivity of substance P and other excitatory amino acids. Overall, reduce IL-1 beta, TNF alpha, IL-6. Those inflammatory paradigms that on a systemic basis are breaking down articular cartilage. That's pretty interesting. That's really very, very interesting. And it's something I experience personally. I nebulize about every 6 to 8 weeks because I have seronegative spondyloarthropathy. I used to take handfuls of curcumin with CBD, right? I never did THC because I'm not a fan, right? But I didn't care about THC. I cared about the CBD because it works better for pain. The problem is that CBD is a terribly weak anti-inflammatory. So unless you combine it with something like curcumin, or you combine it with something like curcumin and resveratrol, wonderful study demonstrating that curcumin and resveratrol has a synergistic effect, right? Then you can modulate central sensitization of pain. What about diabetes? This is fascinating, wonderfully fascinating. With increase in sympathetic tone, what happens? With increase in sympathetic tone, we get dramatic release of insulin from the liver. Our liver starts to boom. And our muscles become less resistant to storing glucose. So if the liver is shooting out glucose and the muscles are not receptive to taking in glucose with sympathetic tone, right? Elevations in sympathetic tone, this means higher circulating blood sugar levels. This means requiring more insulin production from the pancreas and pancreatic islet cells. This means greater insulin resistance. This means fatiguing of pancreatic islet cells. This is what leads to diabetes. So if we can stabilize sympathetic tone, create more homeostasis, now we have muscles that are taking in more glucose. We have a liver that's not expelling as much glucose. Our circulating levels of blood sugar decline. The requirements for insulin lessen. This is fascinating. Just by downregulation of central inflammation, just by downregulating central sensitization. So is there more? Well, actually there is. Inflammation also sensitizes the hypothalamus. Well, what happens with tremendous inflammation in the hypothalamus? Well, the hypothalamus becomes less sensitive to leptin. Leptin is that peptide, that protein that tells our brain that we're full. Well, with increase in sympathetic tone, increase in inflammation, and our fight-flight response is just on tweak, right? We're hungry. We need to fuel ourselves. There is no element of satiety. We don't feel full. Think about any sporting event you've ever watched. If you watched the Olympic hockey game and you had a bag of chips in front of you, whether it was the women's or the men's Olympic gold medal hockey match, if you had a huge bag of chips in front of you, I guarantee you all finished the huge bag of chips. Because there was no signal from your brain that you were full. Your sympathetic tone, your fight or flight was through the moon, right? You're drinking, you're eating pizza, all of these things are inflammatory. Your hypothalamus was like, hey, we're not sensitive to leptin at all, right? Knock down a second bag of chips. Yes, I know you knocked down a full medium pizza yourself, but there's another pizza there, so have another beer, let's grab another slice, right? But if you can reduce inflammation systemically and centrally, you can stabilize inflammation in the hypothalamus. The hypothalamus becomes more receptive to leptin, and your personal experience is that you're full. You're satiated. I don't need another slice of pizza. I don't need to have a second chicken sandwich at Chick-fil-A. I don't have to go to In-N-Out and get a double-double and then go back and order a large chocolate shake. This is fascinating. This is really impressive stuff, right? What about neurodegenerative? We have a stroke. Tons of inflammation from blood. What happens in that scenario? With all of those inflammatory mediators, if the body's not able to down-regulate inflammation, what happens? Well, no different than kind of radius or sculpture injected into your face, right? The microglia in your brain require an environment that's stable. They need homeostasis. In states of dramatic inflammation, elevated NFK beta, elevated inflammasome paradigms, elevated IL-1 beta, TNF alpha, IL-6, what happens? You end up moving your microglia from an M2 state or a proliferative state to a degenerative state, a catabolic state, an M1 state. In that scenario, you end up getting gliosis. You end up getting fibrotic depositions around your microglia. That fibrosis and that scarring of microglia is synonymous with breakdown of collagen around myelinated nerves in the brain. So the very same inflammation that's causing scarring around your astrocytes and in all the microglia in your brain is also denuding the myelin in the dense irregular tissue, the type 1 and type 3 collagen in all the myelinated nerves in your brain. Together, what is that doing? It's reducing synapse time. It's reducing the balance, the neurochemical balance in the brain. And how do you experience that? You clinically experience that with impaired mentation, with cognitive decline. So if I can down-regulate central inflammation, if I can down-regulate the process that's going to denature the collagen around my myelinated nerves, that's going to cause fibrotic scarring of my microglia and gliosis, can I potentially forestall neurodegenerative decline? On a theoretical basis, yeah. Theoretically, yes. Everything here that we're discussing is experimental use, right? Very experimental use. I am not saying you're going to treat Parkinson's, ALS, MS with any biologic, let alone an umbilical cord-derived mesenchymal stem cell exosome. I'm not saying you're going to treat diabetes. I'm not saying you're going to treat cardiac disease or treat pain. These are all disease states. You cannot use any biologic to diagnose, treat, cure, prevent disease. What I am saying is that there is a central inflammatory paradigm that is common to some of the most catastrophic diseases in modern medicine that affect all of us and everyone in your community. How will we know if intranasal delivery of any device, let alone a handheld nebulizer, will impact a patient's quality of life? Observational studies. Take a patient who's got early stage dementia, right, and track their outcomes. Patient reported outcomes, 0, 3, 6, and 12 months. What about a diabetic? Patient reported outcomes, maybe a Lingo or a CGM, track daily variations in blood sugar, track quarterly HbA1c. What about cardiac? If we're modulating or potentially down-regulating osteoblast activity in smooth muscles, if we're down regulating cholesterol deposits in vascular permeability, serial cardiac calcium scores. Fabulous way to assess issues. Echocardiogram, right? And just, this isn't going to dramatically affect lipids that I'm aware of, right? So checking somebody's LDL cholesterol or cholesterol HDL ratio, probably not going to see tremendous changes in that, right? But cardiac calcium score or even carotid ultrasound may not be a bad idea. Maybe every 6 months. Pain. High sensitivity CRP, SED rates. Tracking their functional outcomes, right? What happens in pain when somebody's just miserable? Part of that pain experience is they don't sleep. If you can down-regulate inflammation and it can stabilize hypothalamus, do you think it stabilizes the reticular activating system? And by stabilizing the reticular activating system, does it increase the likelihood that somebody will have better sleep architecture and sleep better? And do we know and have tons and tons of literature that demonstrates that people who sleep better heal? And sleep disturbance is one of the primary issues in quality of life for people with pain? Yeah, you betcha. I understand this is a lot of information. I understand this is theoretical. Why do I present this? I present this because I look for patterns. Just like I look for patterns when I was looking at early, PRP and BMAC and SBF literature, and sure enough, all of those authors did in vitro and vivo studies and they spiked their products with fetal bovine serum. And then I looked at fillers, and sure enough, all the companies that have FDA approval for fillers, right, whether it's Radius or Sculpture or PDGF, all of them used fetal bovine serum as well to spike their product to get a better clinical outcome. I'm not looking for zebras, I'm just looking for horses. I'm looking for commonality in things that makes sense and that centrally ties disease together or centrally ties market motivation, whether it's good or bad, right? And ultimately all I'm looking for is, there's so many hard things that we do in medicine to try to remarkably impact the quality of a patient's life. If we can make it as simple as sticking something in somebody's nose, and I'm not saying we can, but I'm saying at a minimum, isn't it worth the academic exploration to see? I mean, when you have cardiac patients and they're on 3 blood pressure medications and they're on a GLP-1 and they're on all this other nonsense, right? And hell, they can't get up out of a chair and walk across the room, right? If there's a possibility with something wonderfully non-invasive to improve their quality of life, I didn't say treat their cardiac disease, just to improve their quality of life, isn't that worth it? Somebody with, type 1 diabetes, where we know almost all type 1 diabetics end up dying due to, fluctuations in blood sugar. And it's usually, they go low, they go hypoglycemic, and either their dog or whoever's looking after them wasn't there. And they end up dying of hypoglycemia. I have a colleague, wonderful colleague, brilliant individual, type 1 diabetic, had an insulin pump, died of hypoglycemia. Super healthy, kept his glycemic range super, super tight. 6% body fat, wonderful athlete, brilliant individual. I have no idea if something like this may have improved his quality of life. I have no idea if, the insulin demands for him would have been less. I don't know. But what I can say is that as a population in general, we're getting more sick. They're putting more nonsense in our food. They're spraying all of our fruits and vegetables with more toxic chemicals. None of that is good for us. All of that is pushing our bodies towards an M1 state, a predominant state of inflammation and catabolic breakdown of tissues. And if there's something we can do that's non-invasive that will move people from an inflammatory state, M1, to an M2, a stabilizing and reparative state, I think it's well worth the investigation. I'm Dr. Martin. Have a very blessed day.